morning, everyone. Welcome. We've ordered some beautiful weather for you, so I hope you all enjoy the view today. It's stunning, isn't it? So my name's Chris Norton. I have the privilege of chairing the steering group for the Ibd Pain Collaborative Network, and I'm chairing this morning, and then my colleague Elsa Hart is chairing this afternoon. So welcome. We're so excited to have you all here today. As you will have seen from your lovely snazzy brochure, our key objectives for the Pain Collaborative Network are to facilitate knowledge exchange between researchers and IBD researchers and pain researchers, to foster a culture of sustainable international collaboration between leading pain and IBD researchers, and to drive world-class research into this issue. So a few practicalities before we start. You may not have seen the loos on the way in. They're cunningly disguised in the wooden panel work on the way in, so you do have to search for them a bit, but they are between the door and the lift, and the lovely ladies on reception will let you back in again if you do need to go to the loo. We're not expecting any fire alarms today, so if by any chance we have one, again the ladies on the desk there will direct us to the fire exits. So this is our first meeting of the Pain Collaborative Network, and you've got your programme in this snazzy brochure, so we'll be trying to keep to time, and I would ask all our speakers to try and keep to time. We'd really like to thank the Foresight Group for donating us this wonderful venue. I think that was really a master stroke, so thanks also to Nicole for facilitating that. So this collaborative network has really come from an identified member need from Crohn's and Colitis UK, and I think a lot of us feel that a new approach was needed, that we'd actually gone so far. They've already funded 3 PhDs in IBD pain, but really we needed to take this whole area to the next level. And I think feeling that probably IBD is not unique in pain, and there's a lot of lessons and cross-fertilizations that need to happen that haven't been, except on small scale so far. So this is really a networking meeting, and I'd really encourage you to use today to talk to people you don't know. Don't just talk to the people you do know in the audience, but talk to each other and try and work out where we can take this area. We've got participants from a very wide variety of backgrounds. We've got patients, we've got clinicians, we've got IBD researchers and pain researchers, and some basic scientists here. So Crohn's and Colitis UK is putting some resource into this and some funding, but I think really that the key for today is how we can collaborate and take this area forward. So all ideas are welcome. But we were going to start this morning just with a few key people outlining for us how they see this issue from different perspectives, trying to just get the conversation going. Then we've got some stunning keynote speakers this morning from all over the world, which is wonderful, and then we've got networking workshops this afternoon. So please participate, but we also really want to hear from you on ideas of how this network can work in practice and what you'd like to see in terms of the network. So we're starting with some just general discussion really from a panel here. We've got David Bulmer, we've got Amanda Williams, we've got Stephen McMahon and Miles Parks. And I'd like to just start by thinking, for each of you, what are the areas of unmet need in IBD pain from your perspective? So Miles, I'm going to put you on the spot with your mouth full of biscuit.
No, well done, thank you.
So as a clinician really, first of all maybe, how do you see this issue in your clinical practice as a gastroenterologist?
Well, I mean, I think in some senses there is a distinction between the pain that we sort of understand, and which is probably a relatively small subset of the total body of pain in IBD, I think. The pain that we can understand is the sort of pain that you can, as it were, see. You look inside with an endoscope and it looks horrible and ulcerated, and we can all understand why that's such a wretched thing for patients. But there's a much, much bigger part of the iceberg underneath the surface of people putting up with pain day to day, where to a clinician's perspective, it's much more difficult to understand. The bowel itself looks okay, doesn't have those deep ulcerations and what have you, but nonetheless the patients, if we ask them, and clinicians are not always very good at asking people about these symptoms, we'd like to ask about things we understand, and we're less good about asking things about things we don't understand. But it's clear that there is this huge part of the iceberg that we don't really understand. And I think getting to grips with that and helping our patients to manage that day to day is a big part of what today is about. To some extent, I think if the pain due to ulceration is a different question, in the sense that we can control the ulceration, we can control that type of pain, but it's this other thing which I think is such a big problem, probably, and is in part why I'm sure we as a clinical community of doctors and investigators, but doctors in particular, have probably slightly ignored this.
Right, so Stephen, do you want to say just who you are and where you're coming from in this issue?
I'm Steve McMahon, and I'm coming literally from just downstairs because I work in the government campus. I've spent the last 30 odd years studying pain mechanisms, trying to understand the pathoneurobiology of pain, although not specifically in the context of IBD. And so coming to this meeting, what strikes me are several things, but the most prominent is that our knowledge of IBD pain is as bad as all other pain states, or in many cases much worse, I think. So I think we're starting in a worse position. And so I'll give a few examples of that. So one will be in terms of mechanisms. So in some pain states, we've got some very clear target mechanisms that we can focus on. So one example might be in neuropathic pain. I think there's a lot of evidence that spontaneous abnormal firing of damaged nerve fibers drives the neuropathic pain in many patients. So if that's true, you have a target to focus on. We can model that event in animals. We, to some extent, can study it in humans. We can really get to grips with the science of that spontaneous firing. In IBD, we don't have that, really. We have, as you said, that we know that some horrible inflammatory muck is likely to stir up and activate nerve fibers, but we don't really know specifically what the mediators and mechanisms are. We don't know enough, a little bit about this type of nerve fibre in comparison to other nerve fibres, but we really don't know enough about those fibres. And again, another parallel that strikes me in the arthritis field, a lot of rheumatologists said, oh, we can treat the inflammation in arthritis, in RA, and therefore we're done. All the swelling goes away, there's no problem anymore. And I do wonder if there's been a little bit of that echo with clinicians treating IBD.
Sure.
We can treat inflammation. But as you know, and I'm sure we'll come on to, that treatment is not really sufficient in its own right. So I think in mechanisms, we are significantly worse off in not really understanding what the targets would be for treating pain. And similarly, as a scientist who works in the laboratory, we have often relied on animal models, and in the pain field generally, animal models are not great. They've all got limitations. We don't know when an animal's in pain is the reality. I mean, obviously we can infer it in many ways, but we don't know for sure. And so we don't really know that we're measuring the right thing. And we certainly don't know that our models in many cases recapitulate the disease state that we're trying to capitulate. So in this case, we have a few models of doing slightly horrible inflammatory things to the gut, and we hope that that process will mimic what's happening to some extent in patients. TMBS or something else, I strongly suspect that is quite a limited translatability. So understanding understanding mechanisms and improving models, I think, will be useful. And then a third deficiency in this area, if I can keep going, is that the treatments we have available for pain seem to be even more limited in the sphere of IBD. So, I mean, many people with a modest or moderate pain state will go to the chemist and buy some non-steroidal over-the-counter medication, and that must be responsible for a huge number of analgesic scripts and drug taking must relate to those drugs. Well, obviously in this field, that is not really a great option because of the potential side effects in the gut of giving non-steroidals. And then we're also unlucky, perhaps at the moment, that the opioid crisis has really reawakened the idea that started 20 years ago or so that we ought to be using opiates much more widely for non-cancer pain. And I think at the moment anyway, the pendulum is pretty clearly over there, that opiate use is considered a bad thing in non-cancer pain. And in IBD, I see that also is becoming it's becoming a persona non grata really, so that's almost being wiped out. And then again, I mean, although we have some very, we have drugs with very limited efficacy, high NNTs, number needed to treat, we do have some drugs for specific pain conditions. So again, the example of neuropathic pain, we have a bunch of drugs, not brilliant, but we have drugs that are somewhat selective for neuropathic pain. Again, we don't have that in IBD. So I think on the treatment side of it, IBD is a poor relation compared to other painful disorders. And then finally, if I'll finish with one last word, I'd say on sort of diagnosis and stratification, I think it's also a problem, and this is a general problem in the pain field, that we've tended to lump all pains with a common name together and assume that all those people with IBD will be reasonable representatives to enter a clinical trial to test out some idea or other, while almost certainly that assumption is not true, that the patients will have different driving factors for their pain. They may actually have completely different causes for their pain, but even if they don't have different causes, they will have different contributions of pathologies contributing to their pain. And at the moment, we don't have many strategies for identifying people who may have different types of pain with IBD. And as you know, as I think the drug company people here will tell us, not being able to stratify patients is a great recipe for failure in clinical trials. So I think that's another disadvantage for the system. So I'm afraid there's not a lot of good news.
Right, but there's a challenge for all of you. If we can fix that lot, we'll be on a winner. So Amanda, do you want to tell us who you are and how you come,
Sure.
you know, what's your perspective on this?
My name is Amanda Williams. I'm at University College London. I'm a psychologist, a clinical psychologist, and I also work at the UCLH pain clinic and have worked a lot with chronic pain patients of all sorts over the years. There are two main things I want to say really. We know that how people see the world, how they experience the world, how they think about their pain affects their pain. Of course, there's the brain-gut axis, so a whole lot of things happening whenever we all know what happens when we get anxious, when we get upset. Our guts react, so there's that, and there's also central sensitization. So we know about general pain mechanisms, but we don't know any detail at all. We really have no sense of how those work. We can make general associations between particular beliefs or ways of thinking and finding pain more difficult to deal with, more interfering in life, more distressing. But beyond that, nothing very specific. And I think there are important differences among different types of pain. There are different other symptoms that are distressing and difficult to manage that go with the pain often, certainly in IBD. And there are different consequences for people's lives. So the second main issue for me is how we engage patients, and we've tended to use a musculoskeletal model for trying to explain chronic pain. I don't think we've done terribly well with that, to be honest. But it certainly just leaves right out in the cold people with visceral pain of all sorts. Doesn't make any sense, isn't at all helpful. And I think we need to learn much more from patients about how to explain pain, how to build an integrated model that makes sense, because otherwise we just drive patients away. We do have some helpful things to offer from psychology and rehabilitation in general, psychologically informed rehabilitation. But if we make patients feel that we are telling them the pain is somehow in their head or it's because it's a psychological disorder, which I think is complete nonsense, then we just drive them away when we do have things to offer. So I think we really have a lot of work to do in engaging patients and learning from them and how we explain pain. And that needs to go, of course, wider than the patient community. It needs to be to their families and their friends and their schoolmates and whatever. Thank you.
Thank you. Access of microphones. David.
Looking old at this. Space and time. So my name's David Bulmer. I'm from the University of Cambridge. I think Steve covered the unmet need from a scientific perspective very well, and I won't try and add to that actually. I think personally the unmet need here is that we have an opportunity, quite literally I think, of a generation to do something in IBD that's quite unique in the pain field. I think it's a mystery as to why the patients have pain. I think we can access that site of pain in a way that we can't for many, many, many other pain conditions. And I think that's a tremendous opportunity for treating IBD pain. We can move away, as Steve quite rightly says, from these animal models, these empirical observations of we do something nasty that we think might mimic the clinical condition and see if drugs work, yes or no. And we don't really know why they're working, if they do work in those models. And I think we can actually take samples, which is one of the things my group has established over the last decade. From IBD patients, we can show these effects correlate with patient pain scores. So I think we've got a mechanism that drives symptoms, and we can really understand that. And I think just to expand on that, I think in IBD there is, again, I'll say it again, the opportunity of a generation, because we have patients with significant disease with no pain, and we have patients with disease with pain. So the opportunity for comparative studies to understand why the patients who don't have pain is a tremendous opportunity that doesn't exist, I don't think, in other fields. And I would actually go so far as to say we are treating, I suspect, pain in IBD effectively at the moment. My personal feeling is that the anti-TNFs probably are analgesic in those patients, and their pain burden, if they were not on the anti-TNFs, would be much worse. So I do think we have a unique collection of patients and treatments and opportunities to gain access to that human tissue, which will allow us, I think, to crack this nut. So my fear in terms of unmet need is that we won't be able to make the investment in the individuals who I think we have present in the UK at this moment in time to deliver those opportunities. So that's my thoughts.
Miles, can I just get you a microphone? And for the audience who doesn't know IBD, can you just say a few words about the bioresource and what opportunity you think that contributes to this field? Because I think that is a huge potential, isn't it, for us to work on?
So an important point is to flag the fact that Chris here has done a terrific job of bringing some of these sort of iceberg type problems to the forefront of science and the clinical community. So you ought to be congratulated, Chris, for actually being the motivating force behind a lot of this. It's interesting to hear Steve talking about animal models and what have you. As a clinician, I'm working alongside lots of scientists who often, particularly in the field of IBD, have used animal models quite extensively, not just to understand pain, but all sorts of immunological aspects to IBD. I've always found it slightly frustrating. I've always had a bit of a go at my local colleagues in Cambridge about using animal models, because I always say, well, we've got clinics full of people who've got actual Crohn's disease, rather than trying to create an animal model that has something that looks like Crohn's disease. Why don't we work on these people and see if we can better understand the disease as it is? And so, in fact, we've extended that philosophy. So, as you may or may not be aware, for many years the UK has been involved in the world of investigating the genetic basis of Crohn's disease and colitis, just to try and better understand why people get these conditions. And some years ago, the group of us who had been engaged in those sorts of studies, and there are some representatives here in the audience, including Elsa and others, Richard is here as well, others, we decided that it was all very well doing these quite neat scientific studies that were making good scientific progress, but that actually we wanted to ensure that we could bring this full circle back for what we call clinical translation. That's to say, can we avoid collecting stamps and do something that actually helps people in clinics who have got Crohn's disease and colitis? And so we set up, as Christine has said, what we call the Ibd Bioresource. It's been supported by Crohn's and Colitis UK and some other big funders as well. This was with the intention of accumulating a large panel of people across the UK who had agreed to be recalled based on particular phenotypes or indeed by their genetic makeup for downstream studies of whatever type. And that could include, and indeed there are some surveys running at the moment. Chris is leading one of those, Mike Lee here in the audience, another, and I know David Are you using the Bioresource, David? I can't remember whether you were accessing it.
No, but our intention is to
Yes.
do the drop down of Mark.
So very much the intention this bioresource can be accessed by anybody, any investigators who have important questions to ask. You just pop a proposal into us. If it looks like a serious question with some seriously useful outcomes, then it'll be approved, and you can then access the cohort, which now numbers about 30,000 people around the UK with Crohn's and colitis. They can be asked questionnaires, they can be, from the data that we've already got captured on these individuals, they can be particularly targeted. If they've got, if we've asked them about pain and that's been captured on our database, you can go back to them and say, we know you've been troubled by a lot of pain, we've got these additional questions, we want to know if you'd be willing to collect samples, or and so on and so forth. So it's really, the Ibd Bioresource is really there, set up as an important piece of infrastructure, essentially to accelerate research in Crohn's disease and colitis, and to enable access to cohorts of well-defined patients by investigators who may otherwise find it difficult to get hold of patients, either because they are not themselves clinicians, or actually even if they are clinicians, the frustration of having to, having had an idea, to then wait for the relevant patients to come through your clinic, and you can then consent them. And this process always takes about a year or two, notwithstanding getting ethics and all the rest of it lined up. And people have usually forgotten what they were doing by the time they actually get around to getting the cohort of patients through. So the Bioresource is there to accelerate research, to enable us to recall cohorts of well-defined patients who themselves have expressed a willingness to be involved in research, and just to put it on their nose to say, look, we've got this study, we're interested in pain, would you be willing to help? And for the people who receive those emails, they can just reply saying, yes, I'm happy to do this, having read the information sheet, having understood what's involved, happy to participate. But they don't have to participate in all of the studies that come their way. They can pick and choose according to how they're feeling or what their sense of motivation is at that time. So that's the Ibd Bioresource. Any investigators in the room who are interested in accessing that, please feel free to email me after the meeting or talk to me during the day, and I can give you a few more details as to how to apply to it. It's a simple application process.
Just ask you, do you have tissue from those,
We
any
have,
of those subjects?
We own, at the moment, so we are, across the 30,000 people, we have blood with DNA, serum and plasma. We are also recruiting an inception cohort of people newly diagnosed with Crohn's disease and colitis, on whom we are collecting more detailed, including biopsies, and more detailed blood panel and stool samples as well. There's always a tension in setting up something like this, as you well appreciate, Steve, in terms of what's possible versus what we can actually, where the balance sits in terms of getting big numbers in. But the key aspect to it really is the recallability. Yeah. And so, if you do identify cohorts of patients that you particularly wanted to target, and Mike is doing some of this stuff, then they can be recalled, and if needs be, it's not impossible to collect samples from them as well.
I think this is a real resource and a real opportunity that should help us take this whole area forward. So can I ask the panel generally, I mean, what do you see as the real challenges in particularly the chronic pain research? I think the acute pain in IBD hopefully is more or less covered by getting the inflammation under control, not completely, but to some extent. But what are the challenges in chronic pain research generally and in IBD specifically?
Well, I mean, to speak to that, your biggest fear is always going to be redundancy in the system. So particularly if you take a mediator, I think if you take a mediator-based approach, this is effectively what aspirin does, so you block the production of mediators that you think are giving rise to pain. And aspirin works really well in some systems like the head. I don't think we know quite how that would pan out for IBD yet. Maybe we'll get lucky and the pain is so predominantly driven by a number of...
David, is your sense that we understand the mediators of pain in the gut or in IBD in particular?
No. I think we've gone after things we can measure, which is often what we do as scientists, because the pressure is to produce data results and papers. And also you have your prejudices, and I think coming back to TNF, for example, I think if we'd have found TNF under different circumstances, observed what it did to sodium channels, you would sit there and say, this isn't a cytokine, this is a mediator that changes neuronal activity. Right. And so it's no surprise that it's involved in pain. Yeah. And that's not how the story went. Mm-hmm. So, perhaps there are other mediators in the gut, particularly the L6 family, I suspect, are very important, that could be involved. But there is that issue of redundancy, so if you've got several mediators and you take out one, will it be successful? It's hard to say. And certainly if you look at the nerve, the next chain in the link, nerves are there to detect a whole host of potentially noxious stimuli. So you want diversity in your detection system to alert you to potentially disastrous events. So that is probably the biggest challenge. But nevertheless, you can directly target the nerves and just switch them off. So I think, you know, there are some issues with some approaches. We get forced into maybe developing those because they're the tools we have and the drugs we have at that point in time. But I do think there are ways around those issues, and I think there are approaches that are more likely to be successful, you know, with the caveats of side effects, so on and so forth, we can get them to work. So I think, you know, because there's such a lot of activity in IBD from an immunological perspective, if you had detailed pain assessment in those patients, I think we'd be gaining a sense of which are the important mediators now, and that would help.
I'd be interested to know, actually, not just from the panel, but more importantly, probably from the audience and other people. And I hesitate to do this so early in the day. Chris, apologies if this causes it. From the clinical perspective, there's quite a lot of parallels between the pain that people who experience but without inflammation in IBD and irritable bowel syndrome, which is something we see a lot of. I know it gets a lot of patients' hackles up partly because of the confusion there is between IBS and IBD, and a perception that IBD is a more serious, in inverted commas, condition. I'm not sure that's completely fair, in honesty. I think that stems probably, again, from our clinical perspective, whereby we have, as a community, traditionally been rather dismissive, the medical profession, I'm afraid, of people with IBS, and I think that's wrong as well, actually. But there, as I say, there are these parallels. Often the features of the pain seems quite IBS-like, and people who've got IBD, Crohn's disease and colitis will have perhaps sometimes seen written in the letters, this looks more like IBS. And partly we jump to that because we're talking about people in whom the inflammation seems to be well controlled, there is no inflammation, it looks normal, and then patients are still getting pain. And so there's, on the one hand, there's a bit of a leap towards that, it must be IBS because there's no inflammation. On the other hand, there are some quite distinctive features, and Elsa and others, I'd be interested to hear your thoughts to the extent which your perception is, Richard. Does it feel like IBS? I have this idea that you get a post-inflammatory irritable bowel in the same way as there's a very clearly defined entity called post-infectious IBS. So in some people, an infection will trigger IBS or irritable bowel. Irritable bowel, I should say, is very common. About 15% of the population have IBS. And so it's not surprising, therefore, of course, that 15% of people who've got Crohn's disease and ulcerative colitis also have IBS, so that would be surprising if that weren't the case. But there probably is a much bigger proportion of people. And are these two things linked? Is it helpful to link them, or is it actually unhelpful to do that? Do people... What can I ask Elsa? Can we just to extend the panel, because there are people in the room here who know a lot more about this and see much more of this than I do.
Yeah, so I think it's a perfect opportunity to study these patients because we've got IBD with often overlaid symptoms. You think it's just a bit more. You've got IBD where their inflammation is controlled, and you can kind of measure that endoscopically with the calprotectin, and then you've got IBS. So in a way, you've got three nice groups where you can actually study some of these particular things. I think the Crohn's cohort is a really, really messy group to look at. Some of those got perianal disease, and it always strikes me that they, sometimes they don't feel any pain, and their bottom is an absolute disaster. Yet they don't feel pain, or they can have had operations, or have strictures, or lots of other things that can go on. So I wonder if the neater group is ulcerative colitis with active disease, ulcerative colitis without active disease, and then IBS, to really drill in on some of these pathways. Because Crohn's is so messy.
Yeah, it is strong.
Some thoughts about how to actually, it's the classification, and I completely hear what you were saying, Steve, about unless we classify pain better, whether it's the psychological bit, whether the patient feels it's more that angle, this is where the patient fora are going to have to tell us about how to classify pain. It's not us to classify it anymore, it's them to say what their experience is. Post-op pain, people who've had operations feel different pain, completely different pain from patients who have not had an operation.
Right, I'm afraid in the interest of time, I think this discussion could carry on all morning, but actually it's a very good point.
Can we give Kazim a moment? Kazim, we've got a world expert in IBS here. We shouldn't pass up the chance to get a clinical world expert IBS expert.
IBS is going to disappoint you. I don't know anything about the condition. really in its own, the way it's often described is actually very loosely termed IBS. Everything that cannot be explained through investigations get termed IBS, and I think that's one of the issues here. That is basically a phenotype, I think, which is pain sensitive. And they don't just have pain in the gut, they have pain elsewhere as well. There is muscle. So it's a pain sensitive phenotype, then gets an infection or gets inflammation from IBD, and the pain gets exacerbated and doesn't settle down. So the system gets more easily sensitized. But I think what Amanda said was very important, that this is an integrated system. You just can't look at one end, which is the gut. It's the gut and the brain.
The whole thing.
And it's the whole thing. And there are these descending pathways from the brain to the spinal cord, the gut, and so on, and which are just as important as well. And I think the more we think about that integrated approach to actually solving this problem, the further we are going to actually get.
Thank you, that's very useful. And I hope those of you in the audience who haven't participated so far have got some ideas of who you want to network with and who you want to catch at the coffee break. But thank you to the panel. And I think...
We're going to sit down.
You can go and sit down.